Gabby asked me to talk about Cardio-Obstetrics, which is an upcoming field, a new specialty niche, although it's been around for a long time, but we've started to rethink Cardio-Obstetrics from the prevention angle. And I think I wanted to really talk and focus most of my talk on what can a cardiologist do to help obstetricians and gynecologists in fighting maternal mortality and reducing maternal mortality in this country. So with that, I am going to start off with my talk. Hopefully we can advance. All right, so the basic summary of my talk is really to give us an understanding of where the field of cardio-obstetrics is moving. We want to recognize that cardiovascular disease is the leading cause of pregnancy-related maternal mortality and pregnancy-related morbidity as well. And we have recognized in the last few years, especially in the last couple of decades, that adverse pregnancy outcomes, such as hypertensive disorders in pregnancy, such as preeclampsia and gestational hypertension, gestational diabetes, preterm birth or preterm delivery, small for gestational infant, have been associated very strongly with adverse cardiovascular outcomes and adverse cardiovascular events in a young woman's life about a decade earlier than if they were not to have adverse pregnancy outcomes. And that's really the crux of my talk today. It will also focus on cardio-obstetrics and the new focus on prevention, early detection, and optimal treatment of cardiovascular disease during pregnancy and in the postpartum downframe. But what we also need is to really rethink how we teach cardio-obstetrics and when to teach cardio-obstetrics and what's the best way to design a curriculum so that it's impactful and leads to a lasting change in the way our trainees think about this field, so that it can disperse into the communities and into other institutions to bring about real sustainable change. Our training and our health policies really need to urgently implement these strategies so that we can improve the education and health promotion of these women. So the three objectives of my talk are to discuss maternal mortality and the stark racial disparities in this country, and focus on some pregnancy-related metrics that a cardiologist needs to know. Also to focus on adverse pregnancy outcomes and long-term cardiovascular risks, and I'll talk a little bit about each of these pregnancy outcomes, mostly focusing on preeclampsia, which is the area of my research, and also to discuss the development of competencies in cardio-obstetrics. And I would say, Gabby would tell you, competency is not proficiency. So I think we have to start somewhere first. So I think we'll talk about what we can do to sort of teach this in a better fashion than we currently are. I'm going to start off with a case. This is a patient that was referred to me by her primary care doctor really to talk about her cardiovascular risk. She's a lady who has developed a peripartum cardiomyopathy. And she was 28 and it came in with 2 antihypertensives already on metoprolol and lisinopril that were initiated because of cardiomyopathy. I took a detailed pregnancy history, and what I found was that at 22, she was admitted during her first pregnancy at 34 weeks and delivered a small for gestational age infant. 3 years later, she came back again. This time she had preeclampsia, which was severe and necessitated an emergent delivery at 36 weeks. This is her second adverse pregnancy outcome in her second pregnancy. Came back again 3 years later, had preeclampsia again, and developed iatrogenic preterm delivery and had to be delivered at 38 weeks. Really did not interface with a cardiologist or a primary care doctor, was referred about 4 months later when she was admitted back into the ER with acute decompensated heart failure, and then was diagnosed with peripartum cardiomyopathy. So, you know, this lady had very specific questions for me. Her first question was my cardiomyopathy preventable? And why did this happen? Will I need to be on medications for the rest of my life, or will my cardiomyopathy improve? And what are my cardiovascular risks? And while she was telling me, you know, her concerns about being a young mother with peripartum cardiomyopathy, I kept thinking to myself that this lady was telling us that something was wrong with her for many years, and we just didn't recognize it. And so I think really, for me, that's really the important piece of the information that I would like you to understand from this talk. United States leads the world, the developed world, in maternal mortality. Maternal mortality is a hard public health metric. It's one of those metrics that really are used to determine a nation's commitment to health equity. And we're not doing very well. In fact, our maternal mortality has grown in the last 2 decades and is higher than any of the other developed countries. And that's actually a really cause for concern and should really stop us in our tracks and make us think about why that may be. And while there are many reasons for it, advanced maternal age, more women getting pregnant later in life, and also increasing contribution of cardiovascular risk factors such as diabetes, obesity, hypertension, increasing over hypertensive disorders of pregnancy over time, I think one of the things that really strikes when we really look deeper into these metrics is that a Black woman in America has about 4 times more likelihood of dying in this country than the white counterpart. And even if you adjust for educational status and social determinants of health, that kind of maternal mortality, which is a race specific, still stands out. So I think it makes us stop in our track and think about the real disparities of healthcare and how we need to sort of focus on trying to eliminate that. So what are the causes of pregnancy-related deaths in the United States? This is CDC data from last year. And if you really look down into cause-specific pregnancy-related deaths, you'll see that cardiomyopathy, other cardiovascular conditions, which include pulmonary hypertension, adult congenital heart disease, ischemic heart disease, SCAD, and cerebrovascular accident, really constitute a significant portion, about 33% if you really tally them all, and hypertensive disorders of pregnancy as well. And so this is the real problem. These women are dying, and they're dying from heart disease. We have been very good at controlling hemorrhage. We have got safety bundles now that help us initiate a really good safety care for these women that get pregnant. And even with hypertensive disorders of pregnancy, mortality is not very high. But they're dying not maybe during pregnancy, but afterwards. And pregnancy-related deaths are deaths due to a pregnancy-related cause for about a year after the woman has delivered, and they're dying of cardiovascular disease. So what are the trends of pregnancy-related mortality? And if you really look at the pregnancy-related trends from 1987 to 2013, you'll find that the contribution of cardiovascular condition, cardiomyopathy, cerebrovascular accident has increased over time. This is why it's important for cardiologists to recognize the contribution of cardiovascular disease in pregnancy-related mortality. This is a review that came in from 9 maternal mortality review committees. It's published through the CDC census data that looks at what are the causes of pregnancy-related deaths and then divides them into preventable versus non-preventable. And if you really look at the cardiovascular causes, it's stark and it's staggering to see that about 70% of these cardiovascular deaths were preventable. And that's where I think we need to stop and pause and think about the number of deaths we can save if we really focus on this as a problem. A deeper dive into that data will tell us, the distribution of the contributing factors. And if you really look at the distribution of the contributing factors, the 3 main things that stand out are patient and family factors, systems of care, and provider care. And 34% of these pregnancy-related deaths are from providers delaying the diagnosis, incorrectly diagnosing them, ineffectively treating them, and ineffectively referring them. And I think that's important to recognize. In terms of systems of care, inadequate communication between referring doctors, inadequate care, lapses of care is something that needs to be rectified. And in terms of patient and family reasons, the patient's self-perception of problems, warning, not recognizing warning signs, not recognizing the need of care. So that's really the focus of what we need to do in the field of cardio-obstetrics if we have to change the trajectory of these women. A little more careful information into when are these women dying. So when you really look at the data, this came out of the School of Public Health at Hopkins. Andrea Craig is one of my collaborators from the School of Public Health. And when they did this study, they really looked at pregnancy-related mortality in the US from 2011 to 2013, what they found was the major part of the timing of maternal deaths was actually not when the patient was interfacing with the physicians or with the providers. It was when either before delivery or after delivery. If you really look at the data, a significant portion of these women actually died 7 to 365 days postpartum. And this is another piece of information that adds to that existing knowledge. In terms of causes of pregnancy-related deaths, they also vary over time. So this was data that came out of 13 states, maternal mortality review of 13 states, and it broke down the causes with the timing. So with during pregnancy, day of delivery, 1 to 6 days postpartum, and while most of the causes during pregnancy and the day of delivery were related to obstetrical issues, one thing that does stand out is 7 days to about 365 days postpartum, the contribution of cardiomyopathy, cardiovascular conditions, and cerebrovascular accidents is much higher. And it's important for us to reflect on this because many of these women actually don't see cardiologists about a year after they've delivered, unless they've had significant problems or unless somebody has referred them to us, like in the case of my patient who had 3 different adverse pregnancy outcomes over a period of 8 years and had not seen a cardiologist. And I think that's what we're facing, and that's where we have to really step in and work shoulder to shoulder with our obstetrical colleagues and make a change. What are the trends in pregnancy hospitalizations and cardiovascular disease? So what we do know is that hospitalizations in women from cardiovascular disease has increased. More women with existing cardiovascular disease are getting pregnant, and it has increased about 25% from about 2002 to 2012, which is when the study was done. This was looking at delivery hospitalizations from the national inpatient sample that looks at delivery hospitalizations across the United States, and there were many, many deliveries over a span of a decade. And what we found that existing congenital heart disease is still the major cause of cardiovascular disease in pregnancy, but mortality was not very high in this age group, either because either because they weren't, the sicker ones, the WHO class 4, class 3 probably didn't get pregnant, or because of the strides adult congenital heart disease and pediatric cardiology has made in the lives of these women. But mortality was highest in women with cardiomyopathy and pulmonary hypertension, and that is considered a significantly high-risk group, and I think really needs some thought from our perspective. What the study also showed is that hypertensive disorders in pregnancy increased over time, preterm births increased over time, and small for gestational age increased over time, as in our patient. Multiple pregnancies, preeclampsia, even though she's young. And that's important to sort of focus on. So how do I think, and how are we thinking about cardiovascular disease in pregnancy? And while we do recognize this congenital heart disease and pulmonary hypertension and arrhythmias, venous thromboembolisms, cardiomyopathies add a significant morbidity and mortality to this age group, well, we do know that adverse pregnancy outcomes such as hypertensive disorders of pregnancy, preterm delivery, gestational diabetes, small for gestational age infants are carrying a significant risk. We do know that advanced maternal age and hypertension and obesity and dyslipidemia and insulin resistance is on the rise. And that's where the field of cardio-obstetrics and prevention and cardio-obstetrics focuses on trying to catch these women early in their trajectory. Maybe pregnancy unexposed a risk that we need to work on and change the trajectory of these women. So what are adverse pregnancy outcomes? Very quickly, I just talked about them. These are 5 that we really think about. Preeclampsia is one of the most common ones, followed by preterm delivery, gestational hypertension, intrauterine restriction. And I also like to think about HELLP syndrome and peripartum cardiomyopathy as a continuation of preeclampsia, or kind of the same as preeclampsia, but more severe. HELP syndrome is a more severe form of preeclampsia, and cardiomyopathy coexists with preeclampsia in a significant portion of women, and I think it's important to know that. And so these are guidelines, the AHA consensus statement that came out in May of 2020, because we recognize this as a problem and something that the ACOG and AHA has been working on together to sort of focus on continuation of care. And what we do know is that hypertensive disorders of pregnancy are 4 major types. Preeclampsia is early onset or new onset of hypertension greater than 140/90 millimeters of mercury after 20 weeks with significant proteinuria. And gestational hypertension it's seemingly not so benign sister, which has new onset hypertension and but in the absence of proteinuria. And then also women who've had chronic hypertension that develop superimposed preeclampsia in pregnancy. And there are some maladaptive changes in preeclampsia that have been studied, have been reported. Wendy Yang, Arinmi Kos, Pamela Yang is from our Women's Cardiovascular Center here at Hopkins. And they sort of talked about this early on in 2017 as to what are the possible changes in preeclampsia that should really alert cardiologists and obstetricians to act swiftly. What we do know is the cardiovascular system and the renal vascular system goes through a lot of change during pregnancy. While there is an increase in cardiac output, about 30 to 50%, starting from about 5 weeks of gestation to about 34 weeks, and even in the end stage of labor, and there's a decrease in SVR, that sort of adaptation is impaired in preeclampsia, where SVR increases and mean arterial pressure increases, and there's actually a decrease in cardiac output. There's also a maladaptive change in the renal system. We know that plasma volume and flow increases by about 75% in a normal pregnancy, and that is not seen in preeclampsia. Metabolic changes are also affecting preeclampsia. We know that there's mild insulin resistance, there's dyslipidemia, which is seen in preeclampsia. And there are certain hematological changes such as subclinical activation of the coagulation system and consumptive coagulopathy of the platelets, leading to the more profound fulminant form of preeclampsia, which is HELP. So we get asked this a lot in the echo lab, especially in women that come in for preeclampsia with severe features, as to what are some of the normal parameters in pregnancy. And I think a cardiologist needs to know this. And this is our study that we published not so long ago that looked at about certain geometrical changes in the left ventricle that happen during pregnancy, which are normal physiological compensation of the cardiovascular system in response to preeclampsia. We do understand that the left atrial and the left ventricular dimensions increase. We know that the left ventricular mass will transiently increase as the response to increased cardiac output and increased response to plasma volume. We know that mitral annulus dilates and there's trace MR, TR, PR, and some trace pericardial effusion. But the parameter that shouldn't be affected by normal pregnancy is the E' tissue Doppler. It is a load-independent parameter, and if it is different in preeclampsia, that should alert a clinician, especially a cardiologist, to dig deeper as to what are some important physiological problems as well as pathological problems in pregnancy that could affect that. And so one study that actually looked at myocardial dysfunction in preeclampsia came from our group earlier in 2018. What they really looked at is echo parameters in patients with severe features of preeclampsia. They had a cohort of about 120 patients, 60 of them were preeclamptic, and they had age-matched gestational cohorts that were normal. And what they looked at was what they found was that there are existing myocardial dysfunction, diastolic dysfunction, changes in LV mass, thickness, in these women with preeclampsia as a response to the pressure and volume overload seen in preeclampsia, especially with severe features. So why may this be happening? What is the cause of preeclampsia, and why does it create such a havoc of the cardiovascular system? The answer is in the placenta. What we have known for a long time is that the placenta of women who have adverse pregnancy outcomes is dysfunctional. Now, whether that is because of oxidative stress or innate immunity or some immune response of the mothers or some genetic factors or some underlying cardiovascular disease that cause endothelial dysfunction, we don't really know. But what we do know is that there is impaired placentation and there's abnormal placentation leading to placental ischemia and placental dysfunction that causes endothelial dysfunction and vascular problems and leads to an anti-angiogenic milieu. And what you see here is a panel of a preeclamptic spiral artery and a myometrium as compared to a normal pregnancy. While the normal spiral arteries, the uterine spiral arteries, are nice and wide and plump and penetrate deep into the myometrium, the preeclamptic pregnancies have spiral arteries that are constricted, they're shallow, and they don't penetrate as well. And so what we've found, and this has been well studied and is also the area of my research focus, is what happens in these women during pregnancy. And what we do know is that SFELT and placental growth factor ratio changes. So SFELT is an anti-angiogenic biomarker. It actually inhibits vascular endothelial growth factor, and that increases because of all of this milieu. And the placental growth factor that is required for the growth of this placenta is inhibited. And this disproportion of SFELT and placental growth factor has been used in other countries as a screening test to screen for early preeclampsia. Unfortunately, it's not available, not FDA approved in the United States yet. It may be. There is a large NIH trial going on in this area, but this SFELT placental growth factor ratio is then associated with all the different manifestations of preeclampsia. So what are the cardiovascular risks associated with APOs? And this is our brilliant fellow, Wendy Yang, who has written a lot in this field. They looked at all the APOs and the 10-year and beyond 10-year risks associated with them. And here you can see gestational hypertension and preeclampsia and small for gestational age and preterm delivery strongly associated with cardiovascular disease, chronic hypertension, coronary artery disease, stroke, heart failure, mortality. Big problem. And so when you break down the adverse pregnancy outcomes into preeclampsia, this is a really wonderful study that came out of the UK Biobank by Pensy Vu from the UK that looked at the strong association of preeclampsia and future cardiovascular disease. And there are millions of other studies that have looked at this, but this is one of the largest. And they really saw that preeclampsia is associated with a greater than 10-year risk, but also very strong, less than 10-year risk. And that's important for us cardiologists to recognize. These are women who are not old. These are women who don't have tons of pre-existing conditions, but their risks associated with cardiovascular disease, coronary artery disease, heart failure, and stroke are actually quite high in 1 to 10 years. And perhaps this is where the focus of prevention should be. This is where health promotion, health education, monitoring of their health status, changing their lifestyle will probably make the biggest difference. We also know that hypertensive disorders, in addition to being associated with long-term cardiovascular risk, are also associated with premature aging. And this was a study that came out of the Brigham Group not too long ago, also the UK Biobank, that looked at the association of hypertensive disorders of pregnancy over the lifespan of these women, and it was associated with premature aging and vascular dysfunction. So how about preterm birth? Again, Pensy Vu from the UK Biobank looked at the same risk of preterm birth and cardiovascular risks. And depending on the timing of the preterm birth, their risk of developing cardiovascular disease is different. And that's really important to know. So while early preterm and late preterm. So late preterm is really preterm birth or preterm delivery, 37 to 37 weeks. And early preterm is a sort of preterm delivery less than 32 weeks. And they were both associated with cardiovascular disease, but early preterm birth was most strongly associated with cardiovascular death. And that's important to recognize. And this is something that recently just came out in August of 2020, also from the Brigham, that looked at the hazard ratios and absolute risk differences in patients with preterm delivery and showed the same thing, where there was a strong association of preterm delivery with ischemic heart disease. And the timing of preterm delivery mattered. And so if you have an extremely preterm birth, your risk of being associated with ischemic heart disease is higher than you have a late preterm birth. So the question is, why? And I think, I make fun of it, but the truth is we know a lot about associations, but we don't know much about causations. And we don't know for sure if adverse pregnancy outcomes truly cause cardiovascular disease and truly change the trajectory of these women. So the gaps in the knowledge must be acknowledged. Does the APO cause cardiovascular disease, or is it merely a risk that is uncovered by APO? And there's a lot of research going on in subclinical myocardial dysfunction, subclinical atherosclerosis in this field, more to come out to sort of deepen our understanding as to why. Can clinicians rely on history alone, or do we need biomarkers? Do we need some important biomarkers that should be checked during pregnancy and postpartum, especially our SFELT or placental growth factor? What happens to them after pregnancy? What should we do to help guide therapy? And can we understand the mechanisms in which cardiovascular disease actually progresses because of APOs? And we don't really know the answers to this. And are there any clues in the placenta? Should we be studying the placenta of these women? There are active studies going on between here, our center, and the McGee group at Pitt that is working to uncover some of these mysteries. So the last question that she had for me is, could have been prevented, and can we prevent APOs? And the answer is yes. To some extent, we can. There is now ACOG practice advisory and bulletin that looks at women with a very high risk of developing preeclampsia, and even in some cases preterm birth, where the official recommendations are for preeclampsia alone, not for preterm birth. But if you've had a history of preeclampsia or type 1 diabetes, or have autoimmune disease or chronic hypertension or multifetal gestation or existing renal disease, you should be on an aspirin, 81 milligrams of aspirin starting 12 weeks and beyond. This reduces the severity of preeclampsia and reduces the side effects from preeclampsia, and is recommended. It's important to note that our patient was not on preventative therapy during her first 2 pregnancies. So what about the association of preeclampsia and peripartum cardiomyopathy? This question comes up a lot, and this is important to know because it is really an important difference that we need to make. What we do know about peripartum cardiomyopathy, that the same biomarkers that are associated with preeclampsia have been shown to be associated in peripartum cardiomyopathy. And we know from animal studies that the placental growth factor ratio and the SFELT ratio that was increased in preeclampsia also is increased relatively towards the end of pregnancy in mice that had peripartum cardiomyopathy. Peripartum cardiomyopathy is a new onset heart failure in the last month of pregnancy to first 5 months postpartum in the absence of any identifiable cause, in the presence of LV systolic dysfunction or LV diastolic dysfunction of less than 45%, and increase in LV and diastolic dimension as well. Now, there are some studies that have come out recently out of WashU that have shown that peripartum cardiomyopathy can be a clinical diagnosis in patients with EFs of 45 to 50% with severe diastolic dysfunction and pulmonary edema. So I think the paradigm of actual diagnosis is sort of something that's more flexible than we originally thought. But there is shared pathogenesis between preeclampsia and peripartum cardiomyopathy, and I talked about this earlier, but many of the inflammatory biomarkers and biomarkers that are anti-angiogenic are seen in both these diseases, as well as many of the risk factors, so extremes of age, multifetal gestation, smoking, and oxidative stress is sort of been studied in both these patient populations. And so what's the relationship of preeclampsia with peripartum cardiomyopathy? This was a study that came out of Columbia and looked at a meta-analysis of about 22 studies worldwide that looked at the prevalence of preeclampsia in patients who actually develop peripartum cardiomyopathy, and they found that where the background prevalence of preeclampsia is about 5% in the general population, in patients with peripartum cardiomyopathy, the prevalence is higher, about 22%, so 4 times more higher in the patients with peripartum cardiomyopathy. And that's important. And that should be, on the minds of obstetricians as well as cardiologists to actually screen for both these problems. And I think it's important to note that. And it's also important to note at the same time is not every preeclamptic pregnancy ends up in a peripartum cardiomyopathy, and not every peripartum cardiomyopathy is preeclamptic. But there is a significant overlap. And I think having a working diagnosis of, or looking or keeping on the back of your mind of a patient with preeclampsia with severe features going on to develop peripartum cardiomyopathy is important, as in the case of our patient, whose 3rd unfortunate pregnancy led to a peripartum cardiomyopathy 4 months later. So can we predict recovery in peripartum cardiomyopathy? And the question is answered that yes, we can in some cases. And this is the IPAC study that looked at an EF dependent recovery. So there are 100 patients, prospective patients, multi-center trial, the first of its kind in the United States, looked at patients with peripartum cardiomyopathy that he had EFs less than 30% and greater than 30%, and followed them on top of guideline-directed medical therapy for about a year. And patients that had EFs of less than 30% generally didn't recover, didn't do well, had more events. And really did not recover their EFs completely. So if you have a patient who comes in asking a question, is my peripartum cardiomyopathy going to recover? I think there is some understanding that it really depends on LV dilatation, remodeling, LV strain. And there are some studies that look at strain analysis of both RV and LV, and I didn't put that in my talk today, and ejection fraction as some sort of phenotypical variables that need to be looked at. But in terms of how we think about and how we're thinking about prognosticating women with peripartum cardiomyopathy, which was a question that my patient asked me, it's a phenotypical, genotypical, as well as risk factor prognostication. So if your EF is less than 30%, your LV is dilated more than 6, or you've had an LV thrombus, you've got evidence of gadolinium enhancement, you've got increased biomarkers, even in the setting of guideline-directed medical therapy, you have abnormal SFELT, although we don't check for it clinically, and increased troponins, you tend to not recover or do poorly. If you look at family history, if you've got a woman with a pre-existing family history of a dilated cardiomyopathy, that should really alert you to push for genetic testing. There's actually, genotypically looking at 43 genes that were isolated in patients with dilated cardiomyopathy. And what they found was one of the specific genes, which is the TTN truncating variant that codes for titin, which is a core filament, to be strongly associated with both dilated cardiomyopathy and peripartum cardiomyopathy, making us think about peripartum cardiomyopathy as a second head phenomenon in these patients who already have this gene and then end up getting pregnant, and that causes them to develop full-blown phenotypical issues. And so I think for patients that have given us a history of dilated cardiomyopathy in their families, it's important to do genetic testing in the setting of peripartum cardiomyopathy. How can we improve competencies? So this is where I think, towards the end of my talk, and I'd really like to focus on what are some things that we should be doing as cardiologists in the cardiovascular community, working with obstetricians to improve what we know about this problem. And so I tend to think of it that, you have to improve training first, not just for fellows, but at the level of the medical school. When I went to medical school, I really didn't have any exposure to cardio-obstetrics. I think sort of most of us can admit to that we learned as we saw these women. But understanding basic translational and clinical questions, we don't have large-scale registries of existing cardiovascular disease in our country. The CARBEG is Canadian, the ROPAC is European. There is no prospective registry in the United States. And that's something that we need to change. We need to change educational resources. I think this has changed in the last 2 years, where programming at our scientific sessions has focused on cardio-obstetrics as an important field that we need to sort of recognize and change. But the last two, I think, are very important. I think physicians are advocates. We are physicians and providers and APPs are patient advocates, and we have to take this further. There's a lot of advocacy issues associated with maternal care in this country that need to be taken up, and I think cardiologists can help obstetricians in that field. And stakeholder partnerships, I think all our societies need to work together to make common guidelines. And I think that is changing now, so that's really great. But the importance of combined cardio-obstetric clinics cannot be stressed enough. I think these women are unique. They need pre-pregnancy counseling. They need important access to care. They need close antenatal monitoring, and they need close postpartum follow-up. In fact, ACOG actually came out with an extensive advisory on postpartum timeframe, and really reshaped postpartum follow-up, recognizing that this is an important timeframe where women are very interested in getting better, and if they have an adverse pregnancy outcome, this would be a great opportunity. And that's really the crux of our foundation of where we have a postpartum clinic for preeclamptic women with severe features who we see with our OB colleagues and MFM colleagues, and I think really help them, and they help us in trying to making these patients better, and it has been hugely beneficial to this patient population. Role of pregnancy heart team, people working together in patients that have diagnosis of coronary artery disease, cardiomyopathy, and adult congenital heart disease, so that there is extensive pre-pregnancy consultation, pregnancy planning, delivery planning, and long-term follow-up. In addition, the pregnancy heart team has a cardiologist, obstetricians, pharmacist, geneticist, if you need one, and social worker working in a team-based, multidisciplinary fashion, so that the care of these vulnerable women is improved over time. So what can a cardiologist do? I put this here. This has been our response to pregnant women before. Just fight, flight, freezing, running away. And I think we need to change that. We should be running towards them. But honestly, I think for me, more than anything, yes, we have to investigate, and we have to educate, but we also have to advocate, and we also have to legislate. And unless we don't do that, real change is not going to happen. And I think one of the major advocacy issues of ACOG, and I think ACC and AHA should support this and work at the statewide level to make this happen, is Medicaid expansion, recognizing that Medicaid population patients lose access to care and lose their Medicaid expansion beyond 60 days. So these are women who rely on Medicaid for coverage during pregnancy, who lose that coverage after 60 days. And if they've had a pregnancy complication, they're likely not to see anybody. And now we've looked at this data that most of the cardiovascular comorbidities happen after 60 days. So that's where I think the important role of working together cannot be stressed more. And California is the first state to actually recently implement Medicaid expansion to about a year. This has been actively legislated in other states. Not in Maryland yet, but it will be. And if we work together. And I think that it's important to focus on this, because if we are to change that, if we improve care, if we prolong their care, we may be able to change their outcomes. This is my patient. She is doing great. She followed every instruction. She lost 40 pounds. Her BMI is normal. Her blood pressure is normal. Her calc score is normal. She's on a plant-based diet. She's no diabetes. She does not have dyslipidemia. And her echocardiogram after 2.5 years of being on guideline-directed medical therapy improved. She's asking me now if she can come off her medicines, and that's a totally important topic that is outside the purview of her talk. And hopefully she can be, and there is very little data to guide us in that frame. That's another area that should change. But this is why I think cardiologists and obstetricians should be working together, because these women are lost. And I think we can really make a change in their lives. So in summary, cardiovascular disease is the leading cause of pregnancy-related maternal mortality. Worse pregnancy outcomes are important, and recognize them. Take a pregnancy history. Ask a woman who is young, who has chronic hypertension, about preeclampsia, preterm delivery, about gestational diabetes. Sometimes that's all they need, and it opens up a conversation that they've never had with anybody before. Cardio-Obstetrics focuses on prevention as well as management of cardiovascular disease in pregnancy, and we really urgently need to change the way we teach this. Thank you for your time, and I'd be